So I'm going to call the meeting to order. I want to welcome everybody back. I hope you all had a great holiday season. You've had a good start to New Year and things are looking up for you. I hope you had a chance to recharge the batteries and you're ready to dive into some more OHP Bridge Advisory Committee work. So a couple housekeeping items to start, which we know we have at every meeting. And these will be shared by Katie either on the slides and or through the chat. So closed captioning should be available to all attendees during today's meeting. If you need access to these, there should be a button at the bottom of the screen that says show captions. Click on that link and captions should begin to show up. If you're having issues or challenges with that, reach out to Katie Waldo. She can help you with that. Questions and comments will be taken from OBAC members only until the public testimony portion of the meeting. If you're an OBAC member and you want to speak, please raise your hand before doing so. For those from the public who are here available, there is time reserved at the end of the meeting. There should be anyway, for you to have public testimony, which we'll talk about when we get to the end of the meeting. So please reserve your comments for that time. The Zoom chat feature in today's meeting only allows meeting attendees to message the host and co-host and no other meeting participants. So just bear that in mind. Any questions, thoughts, or comments can be sent via Zoom chat to the meeting host co-host. If you have a supporting resource link to share with meeting participants regarding an agenda item currently being discussed, share that link with the meeting host or co-host to share with the meeting attendees. All materials for today's meetings are available on the OHP Bridge Advisory Committee website. Also, OBAC committee members, you should have received that from Katie a week or two ago, so you should already have that available. If you don't, you can go to the website to find that. Lastly, we ask that all OBAC members remain on camera throughout the meeting, if at all possible. In order to preserve bandwidth, we ask that non-members remain off camera unless providing public testimony at the end, and that will be an option available to you at the end if you'd like to show your camera for public testimony. All right, so I will now turn it over to Katie to do roll call.
Thank you, Mike. Okay, we'll just start right off at the top. If I call your name, please come off camera or come on camera if you are not already, and just say that you are present. So Debbie?
Here.
Mike?
Here.
Jonathan?
Here.
Great. Angelica?
Here.
Perfect. Renisha? Renisha, are you on the call?
Yes, I am on the call. Yep, I'm here.
Oh, good. Awesome. Thank you so much. Nora?
Here.
Michelle?
Here.
Askina?
Present.
Fantastic. Nathan?
Here.
Great. Brandon?
Great.
Brandon, are you on the call with us today? Kelly?
Here.
Great. All right, back to you, Mike.
All right, thank you very much, Katie. So just overview of today's agenda. So it's going to include a review and voting on the December OBAC minutes, which we'll get to in a second. Part 2 of our presentation series on OHP bridge funding. Part 1 was last meeting. Today is a continuation of that. Then at the end, there'll be a public comment opportunity related to community engagement. And then I'll have some next meeting reminders and a close for the group. So first order of business, we're going to move into reviewing and hopefully approving the December meeting minutes. So I hope all the committee members had an opportunity to review this ahead of time. I'll give you all maybe a minute or so if you want to pull that up, take a quick glance. And then I will ask to see if there's a motion to approve the draft December OBAC minutes. So do I have a motion to approve the draft December OBAC minutes?
This is Michelle, and I so move.
All right, thank you, Michelle. Michelle has moved. Do we have a second?
Second.
All right, thank you very much. We have a motion and a second. Is there any discussion or questions related to the December OBAC meeting minutes? I don't hear any. So hearing none, I will turn it over to Katie to go through the OBAC members for their official vote.
Amazing. Thank you so much, Mike. Okay, Debbie.
Yes.
Okay. And Mike,
Yes, approved.
Jonathan, Jonathan, do we have a vote?
Yes, approved.
Jonathan, you are on mute, I think.
Sorry. Yes.
Great. Angelica,
Yes.
great. Renisha,
Yes.
Nora,
Yes.
Michelle,
Approved.
Askina,
Yes.
Nathan, Nathan, I know you're driving. Do you vote to approve the minutes? If you're talking, you're on mute. We'll move along to Kelly.
Yes.
Great. Okay.
All right, thanks everybody. It looks like the minutes were approved. So we'll move on to the next order of business. So next up, we're going to have Roger Rosales. He's a senior actuary for OHP Bridge, and also Tim Sweeney, OHP Bridge policy lead. They're going to be joining us to provide the second part of the presentation series on OHP Bridge funding. Last month's presentation, which Tim provided, gave a broader review of OHP Bridge funding streams and the mechanisms, which included deeper dive into the Basic Health Plan Trust Fund and the state's financial levers. He also began discussing where the OBAC might have the ability to influence OHP Bridge financially. In today's presentation, Roger is going to build on last month's foundation and take us through a more detailed discussion on rates and rate setting, which is a key component of healthcare financing, including OHP Bridge. As a quick reminder, again, we will only be taking questions from OBAC members at this time. There's time reserved at the end of the committee meeting for public testimony for our OBAC members. Please remember to use the raise hand function so that we can see when you have a question. Roger will be accepting OBAC member questions throughout his presentation. Very briefly, before we go to Roger, there will probably be a break midway through the presentation, and there'll be a slide that says that. But till that time, feel free to ask questions as they come about for Roger. So, Roger, hand it over to you.
Thank you, Mike. Thank you, everybody, for having me on. Thanks, OBAC Committee, for all your work on the BHP program. My name is Roger Rosales. I'm a credentialed actuary, lead actuary for BHP here at the Oregon Health Authority. So I've been working on this project for the last 2 years or so. It's very exciting. We're off the ground running on BHP and getting people the coverage they need. So yeah, we could go to the next slide. Tim Sweeney is going to chime in and help out throughout this presentation. So our agenda today, we're going to talk about what is a capitation rate. Pretty important. We're going to talk about how we do the rate setting process, what financial restraints we have, how we look at population factors and demographics, how we set rates based on who's in the program. We're going to talk about Medicaid and OHP Bridge here. Then we're going to talk about, the flow of money and control, how that works. There's some special terms in BHP called the risk corridor and RAP payments. And very important, just talk about OBAC and your role in rate setting and what areas you could influence and what you should be considering. Yeah, we could go to the next slide. Yeah, I majored in math, so I'm a math guy, but I'm going to try to put this in perspectives of like why we're doing this and all of that. So if you think about yourself and people on BHP, we all have our own health history, right? We can see our doctors, we have certain things that are that we need to be seen for, sore throats or diabetes and all this. We all have a story, and providers are going to charge us for that, and that needs to be paid for. So our role at OHA is really to come up with a way to pay these CCOs that will pay the providers that will get you and everyone on BHP the care they need. So a capitation rate is a fixed amount of money paid per person to a healthcare provider or organization for the delivery of healthcare services. So we got healthcare services, and we need money to pay for those, and OHA provides a fixed amount of money. Capitation rates are how OHA pays CCOs for the BHP coverage. When you talk about a capitation rate, we determine it in advance. We don't have all the answers. We don't have a crystal ball, but we try to project on what the cost will be, and we're going to give the CCOs the money to cover their population. Capitation rates are defined as a per member per month basis, or PMPM, and they're CCO specific, and they're paid to each CCO around the beginning of the month. So yeah, we could go to the next slide. I think this next diagram will help flesh this out. So for OHP Bridge, the member enrolls in OHP Bridge. Do they meet the qualifications and all that? Once that's determined, they're assigned to a CCO. CCO is a coordinated care organization, and they're grouped into a rate group based on their age. So our age groups are 19 to 44 years old, 19 to 34 year olds, 35 to 44, 45 to 54, and 55 to 64. So we're covering adults here. Okay, we could go to the next slide. So if we think about OHP Bridge from the top, this is the payment to provider flow. You got OHP Bridge on the top. If we go on the left side, we're giving a capitation rate to CCOs. And then the CCOs can do stuff with the money we give them. On the very left side, we have subcapitated provider organizations. For example, we give the CCOs money. They could have an arrangement with some organization, and then that money is going to flow to doctors, providers, counselors, and all of that. So that's one way they could do it. Or you have a CCO, and they're paying their providers that's in their network. On the right side, there's also this concept of an open card fee schedule, where OHP Bridge, we're gonna pay for that upfront to the OHP providers, and it's not going through a coordinated care organization. So that's called open card, or there's a fee for service there. Tim, do you want to hop in here and talk about BHP and all that and how this flows?
Sorry, I had the double mute going. Yes. And so this being the sort of like general big picture flow of how this works in Medicaid, for instance, for OHP Bridge, this is still the case, but just a couple of sort of additional details. This open card fee schedule where folks are getting services and the state is paying providers directly, that is most prominently a thing for OHP Bridge basic Medicaid members who are able to fully opt out of CCO coverage because of their federal rights and get all of their services in this manner, where they see a provider that participates with the state and the state pays directly. Bridge BHP members have to be enrolled in a CCO, but there are still some services that are delivered outside the CCO contract. For instance, there's a certain set of mental health drugs that are often referred to as 7-Eleven drugs, but there's a certain set of prescription drugs that are covered outside the CCO networks and delivered solely through, or that the state then pays for directly. There are some other services as well where this arrangement happens, but for folks on OHP Bridge Basic Health Program, they also have to be enrolled in a CCO in order to to, I mean, to be in the program at all, but in order to take advantage of those services that are outside the CCO contract. So just wanted to put this flow in perspective with how it works for OHP Bridge, because that's a little different than Medicaid.
Thank you, Tim. All right, we could go to the next slide. Let's talk about rate development now and how we actually do this. Okay, we could, next slide. All right, so if you just think about yourself and if we even think about this group that's in this meeting right now, how are we going to come up with some capitation rate for each of us, and how exactly do we do that at OHA, and how do the actuaries do that? So first of all, we could look at each other, and we could look at our member differences. What's our age? Yeah, where do we live? And we're all different. What's our age and what's our habits and all of this? So we could definitely look at member differences. You could also look at region. So different parts of Oregon have different healthcare experiences. For example, the Portland area, they have like Dornbecker's Children's Hospital, specialized doctors and nurses there, so they could get excellent care for kids. People in rural areas maybe need to travel all the way to Dornbecker or somewhere out there to get the care they need. Maybe they need to take a helicopter to get over there. So it's very different by region for the state here. Hospital cost differences too. Each hospital could charge different amounts. They have different networks of providers and all of this. So there's different hospital costs there. We could look at the claims of everybody, who's being seen for diabetes, who's had a history of strokes and all of this, different categories for physicians or hospital services or behavioral health. There could be differences in VBPs or value-based payments, where you're trying to, treat the whole person here and give them like a holistic care. Utilization of services too. There's a few instances here. People could use services more, or each service could go up by a trend, like maybe a service costs 2% more the next year. So there's utilization we could look at there. And we look at data. We look at like 2 years ago to project forward what the costs were going to be 2 years from now or something like that. But things could change in the current year. So in 2025, we could have these program changes in the program, and that could be different from the data we looked at in 2023. So we have to account for program changes. And also in capitation rates, there's considerations for administration costs, like who's working on this. And there's also a built-in amount. So yeah, there's some margin in the amount, so some profitability into the capitation rates too. Yeah, I think that covers that. Very complicated, very hard to do, but try to explain this the best I can. We'll go to the next slide, please. All right, first step in the rate development process is statewide base data. So what we're trying to do is not calculate the capitation rate for each CCO yet. We're trying to combine all the data. We got all the data from the CCOs, and we're going to come up with a statewide rate here. So each of the CCOs will send us data, and we'll adjust that data, make appropriate adjustments, and we'll try to get like a statewide data there. Each CCO is different. They could spend on different healthcare costs. There's that subcapitation piece that I was talking about. Maybe they go through a subcontractor. Maybe there's some incentives to give quality of care. Some CCOs could do that, some don't. And then there's other payments that could be considered, called trying to remember the acronym, one second, the patient-centered primary care homes. So there's one-offs like that there. So I just want to let you know that from the very beginning, we're trying to create this statewide rate. All right, we could go to the next slide. Yeah, so once we analyze the claims data that we received, we have to project a trend costs. How much are the costs going to go up that we think? Is it 2%, 3%? We have to take into account inflation. And I mentioned earlier, you got to take into account if utilization trends are different. Are they going to use it less or more? Are things more expensive? From that point we go to CCO specific risk. Each CCO is different. What region are they in? Which hospitals do they use? What are the hospital factors? And each of them also have a different population mix. They could have younger people, older people, healthier people, not so healthy people. So it's different for every CCO. And we have additional services like dental, maternity, program changes I mentioned, and admin loads and taxes. All right, so I just want to let you know that we're going from a statewide rate to a CCO rate specifically. All right, next slide. Yeah. So I just want to summarize the whole CCO specific rate development journey here. From the very beginning, the state gets a list of all the people on OHP Bridge in the previous plan year. We take those people, we gather the claims data for each of those people. We usually take the last 5 years of each person. BHP, OHP Bridge is a bit different because it's a new program. Some people are coming from Medicaid. Some people are coming from the marketplace where you could buy insurance through a marketplace, and some people are uninsured. So we do not have all the information on these people when we started the program. We're on the third block there. The state projects the future enrollment and makes the necessary adjustments based on the available data. I talked about trend and all that, how the population is going to grow or shrink in each region and CCO area. We're going to calculate the statewide rate for each rate group. The rate group I'm talking about is those different ages. And then once we get those statewide rates for each of the ages, we're going to drill those down to CCO specific rates by looking at regions, hospital variations, and population risk scores. I will talk about population risk scores now. So for each of us, we could get what's called a health risk score. And we use data from CDPS and their model that's out of San Diego. Basically, you can look at our healthcare costs and all that and project like a risk score for each of us. And that helps determine what the potential future costs would be. So we do utilize that data. And then we take further adjustment like taxes, admin costs, and risk sharing arrangements. We'll talk about that later on risk corridors. And then we finalize the rate for each CCO. And we send that off to the CCOs. So the CCOs could send that to the providers to provide care to the members in OHP Bridge. Thanks, Katie, for providing this slide. I know it was a lot of work, but I think it helps summarize what we're doing here. All right, next slide. Is everyone okay so far? Any questions? Okay. So we'll talk about capitation rates. We do have a very standard, a high standard of practice here. I'm an actuary, and the team I work with are a lot of actuaries, so we have to have these standards and make sure the rates are the best that we can make them, and we feel like they're actuarially sound. So a difference here, Medicaid capitation rates have to go through CMS approval and to be determined actuarially sound. But for OHP Bridge, BHP, OHA follows the Medicaid rate development. We follow similar steps and all of that, but we don't have to have BHP capitation rates be federally approved. We still try to make the rates actuarially sound, and it's a projection of what we think is reasonable, appropriate, and what the attainable costs are. We have a contract with each of the CCOs, and we live up to that contract there. But our rates must be developed with accordance of actuarial principles and practices. As actuaries, we take into account like business environments. We take into account a lot of statistics and assumptions and all that. So we need to make sure it's actuarially sound there. We need to make sure the rates are appropriate for the population we're trying to cover here and the services they're going to use under the contract. We are adequate to make sure it meets the requirement of the CCOs. We're specific on the payment for each rate cell, rate group that I talked about. And our rates need to be certified by an actuary and meet applicable federal requirements and rules. So let me just tell you that OHA contracts with Mercer. Mercer is an actuarial consulting firm. Mercer is the one that takes our claims data that we provide to them. They come up with the rates. They make sure it's actuarial sound. The actuaries at OHA do provide input and feedback and analysis, but it's ultimately under their kind of consulting firm that they're signing off on the rates are good. It's a collaboration, but I would just want to let you know that there's an outside consultant here working with us on these rates. Yeah, I think we could go to the next slide. Tim, I think I need you to jump in here soon. I might need a little break, but I'll talk about this. So funding and constraints here. As I talked about, our rates need to be actuarial sound. And I talked about all that, but there's other constraints here. There's the state budget. State funds for OHP Bridge must be approved by the legislature. And we have this BHP blueprint where Oregon defines benefits and coverage available to members as part of federally approved blueprint. So even though in our world we come up with rates and we think it's sound, it's still constrained by other things here. Tim, do you want to speak more on this, on the state budget or blueprint?
Yeah, and just a little explanation or context of how we have this set up is that, like, in thinking about constraints around how we structure the program and what it costs to operate OHP Bridge, actuarial soundness is not really an area where we have flexibility, right? If it costs $100 million to have rates that are appropriately developed and actuarially sound, we can't just decide, hey, we're only going to pay CCOs $80 million and y'all figure it out, right? Like, there's the level of constraint that we have with frankly with state policy, but with the structure of how we develop rates that they have to live within that structure. We are constrained by the state budget, but also the agency can ask for money. So OBAC can recommend more funding, right? Like, it doesn't mean we're guaranteed to get it, but we have this green in a sense of there is some level of flexibility. The state is in control of investment it might want to make into the program. There's state dollars for the state match for OHP Bridge Basic Medicaid. If the state wanted to buy everyone on OHP Bridge dogs, then they could put money in the state budget and buy everybody on the program a dog. Like, the state has the flexibility to do that. And then similarly with the blueprint, there are requirements for how we have to set it up, but the state has flexibility in designing and defining the blueprint. And it's another area where the committee can offer recommendations to OHA, to the state, to say, we think you should consider this change or that change in how the program operates. What was I think said is, we don't think it would be appropriate for OBAC to say, we think you should not worry about actuarial soundness in developing rates, right? Like, that's not an area where there's flexibility, but there are other areas where there are. And so we just wanted to make that super clear in giving this sort of background. if there's no questions, back to you, Roger.
Okay. Yeah. So I think there's a question out there about what does actuarial soundness mean? I can read off this definition really fast from our actuarial standards board. So basically Medicaid capitation rates are actually sound if for business for which the certification is being prepared and for the period covered by the certification, projected capitation rates and other revenue sources provide for all reasonable, appropriate, and attainable costs. So we're really think about all the appropriate and possible costs here, and we're trying to cover for that basically. And we're using scenarios and best judgment and statistics to do that to the best of our ability.
And I wonder if we go back one more slide. I know it's not the technical, but I think the bullets that are in this one, well, again, not the maybe same technical definition that Roger just suggested, but I think the 6 bullets on the slide right before this offer some further comments or some extra detail of kind of like what it means to be actuarially sound.
Katie, is it possible for us to go back one slide? There we go.
Yeah. So yeah, this bottom half here, I think, as Roger said, developed with actuarial principles appropriate for the specific population we're looking at, right? Like to some of Roger's earlier points, there's age breakdown. So if we're building rates for 12-year-olds, we should think about what 12-year-olds need from a healthcare standpoint. And I know that's a bad example because we don't cover kids on this program, but and then again, consider the requirements that CCOs have, like what is covered in the contract, what services are being provided, and certainly, meet applicable federal and state rules. Sorry, I see your hand up also, Mike, but I just wanted to highlight those bullets.
No, it's all good, Tim. I appreciate that commentary. So I've got a lot of questions, at least for this slide. And I'll save my other ones for when we maybe get to a break. What happens if the actuaries say, and it's actuary sound, goes through the process, and it's $100 million, but then the state budget is $80 million? What happens then when there's not enough funding to cover what the actuaries are saying it's going to cost to take care of the members on the OHP bridge?
Tim, you want to go first or me? Yeah.
If you have an initial response, I'm happy to
Sure.
jump in here too.
So
I think.
Yeah, go ahead, Tim.
Oh, go for it.
I'll just say quickly, like the actuaries are kind of required to let them know that we'll probably be over budget here, and we need to think about ways to meet that, or the program's not sustainable. So maybe there's a plan design change, a program change, something like that, to put it in there. But yeah, Tim could chime in too.
Yeah, I mean, I think it's kind of there's a lot of moving pieces here. I think taking out the state budget and thinking more broadly of the trust fund that funds this program, and if we have projections in terms of capitation rates that say, based on our enrollment estimates and the capitation rates that are developed, it's going to cost, more money to serve this population than the state is going to receive, in the federal payments. Then, policy decisions will have to be made to either add state dollars to enable the adequate trust fund resources to pay capitation costs, to change the structure of the program in some way that reduces the cost to live within the funding constraints that the program has, be it the trust fund or state dollars, or this may sound like a more extreme scenario, but I mean, if it was determined that structurally speaking, there wasn't enough money to operate the program in the manner that the state wants to, then something bigger would have to be done. I think where this group can come into a role is as we have forward-looking projections and with the changing revenue picture, if federal funding changes or if the cost projections change, we'll be able to see, oh, there's not enough resources available, something has to change. I think in the very short term, and again, this is projections, but the projections are that the per capita revenue that we're getting in 2025 is more than adequate to cover the cost of the program as they are currently forecasted and built into the cap rates. If that changes, then that I think will prompt a look at the program to see what is needed. I think the vision, broadly speaking, would be that there's funding in the trust fund to accommodate small shortfalls for short periods of time, right? Like with the timing of when cap rates are set and when budgets happen, that there's enough money in the trust fund so that when rates are set for the next year and we do analysis, say, oh, our projected costs are $10 million higher than projected revenue. Okay, well, there's $10 million in the trust fund to cover that. And now we have time to figure out like what's happening the following year. Was that a one-off? Is that a more structural issue? And I think especially with the possibility that enhanced APTCs that are set to expire at the end of 2025, if those are not renewed, then that prompts this conversation of what is the state policy response for 2026? Is it changing the program to reduce costs? Is it seeking additional revenue from some fashion, or something else? But I think the short, simple answer is we can't operate at a deficit for extended period of time. So if that becomes something that analysis suggests, there will have to be program changes to accommodate that.
All right, thanks, Roger and Tim.
Katie, can we go 2 slides ahead? Be great. Thank you. Then we
But
can
really
take-
quickly, Roger, I see Michelle's got her hand up.
Oh, go ahead, Michelle. Sorry, I didn't see your hand.
Sorry, thank you. I just want to make sure I've got a clear understanding. So for each of the geographic areas within Oregon, if a member signs up for Bridge, they are kind of risk stratified based on age alone, not gender. And the CCO for that area is then given a per member per month based on the geographic location and the age of the patient. And they are given that on a yearly basis, or is that a monthly?
Monthly. Yeah.
Did I get it right?
Yeah, you got it yeah. Each CCO has an age band for each person, those buckets I was talking about. And then, yeah, we give them capitation rate monthly for covering that person. Yeah.
So, if we underestimate the complexity of a patient, the CCO is at risk. They take, if they have measures in place to cover theoretically, if they aren't given enough from the Bridge program to still cover the healthcare needs of the CCO patients.
Yeah, that gets into like risk mitigation and risk corridors. So like,
Okay.
yeah, we don't have a crystal ball here. We try the best we can and we're not perfect, but sometimes the CCOs will make money because we gave them too much money for the healthcare services for the person. And it could go the other way too, where we didn't give them enough money to cover that person. So we have a risk corridor in place that's going to take into account 2026, where we're going to kind of look at everything and make sure, yeah, both sides are okay. And yeah, we'll get in that soon. Go ahead. Yeah. Or Mike.
No, I was saying go ahead, Nora.
Oh, just on that same topic that Michelle was raising, I think it's worth noting that each CCO's experience is taken into account in the rate. So in areas where there's more than one, some areas only have one CCO, but in areas where there are multiple CCOs, we recognize that some CCOs may attract folks with higher need, either because they have programs that people like or by accident or whatever. And so the rates are at least theoretically compensating if a CCO has higher risk people, over several years. So.
Yeah, totally agree with that. Yeah, we got that statewide rate, then we make adjustments for each CCO. And then, but when we deliver it to them, we already made those adjustments and we have like age brackets. So, okay, I think, Mike, did you have a question or are we okay?
Nope. Go ahead
Okay.
and continue.
Yeah, we're gonna take a break here soon. I just want to let you know of the timing of the OHP bridge rate development. This was for 2024. It's going to look pretty similar for 2025. But if you just keep the big picture in mind, what we're trying to do is set assumptions. April and May, we get all the data from the CCOs, then we're making all those assumptions and adjustments, looking at it from different points of view, like dental and maternity and risk score summaries and all of this. Then August, we're getting the capitation rate model. We developed that with Mercer. Mercer sends that to us. We're looking at all the hospital factors, regional factors, risk scores. We're sending those to CCOs, getting their feedback and all of that. And there's a final CCO capitation rate certification in September 2024. So yeah, we present them with assumptions and the rates. They look at it. They let us know if they want to go forward with this and participate, and then we get those off and finished. I just want to give you the timeline there. Okay. I think we're ready for the next slide, and I think it's time for a little break here.
Really quickly, Roger, John
Yep.
just got his hand up.
Go ahead, John.
So traveling a little bit further downstream from the CCOs with the providers that are actually providing services to patients who are reimbursed by the CCOs. That is those rates for the services provided is that just an agreement that the CCOs have with the providers, or is it the statewide Medicaid rates that is there an obligation that the CCOs are paying the statewide Medicaid rates then for those services, or is it just up to each individual CCO and the agreement that they have with the provider?
Great question. So in short, it's up to individual CCO provider negotiations for the reimbursement rates that the CCOs pay the providers. In most, if not all cases, and I'm not an expert on this, so I want to like provide the right caveats. The statewide, like the Medicaid fee for service fee schedule serves as a floor for what CCOs should be paying providers, but it doesn't mean that it is the number that CCOs are paying providers. And in many cases, it could be different. Again, subject to that negotiation or the contract agreement. And I'm going to defer to Nora here, who probably can go into more detail than I can.
We do have to pay at least the fee-for-service rates as CCOs, and we have flexibility to pay more, particularly if we see, where there have been gaps. We will do things to try to get providers into our networks, et cetera. We also have flexibility to reimburse provider, if we meet our overall goals, quality goals, we pay the providers for their participation in that work. So we pay them for the services, and then sometimes we pay them extra for helping us meet outcomes and quality goals.
Generally,
Jonathan, it's difficult to hear you.
check.
You're rather quiet. Unless it's just me, but I was having difficulty.
How's that?
A little better. Please hear that.
I'll get close to my microphone. So in my experience, the CCOs generally just treat bridge patients in terms of reimbursement the same as Medicaid patients, or are there CCOs or areas where you would have a different rate that you're reimbursing for bridge versus straight Medicaid?
Well, I can only speak for the CCOs that Care Oregon is involved in, but we don't pay a different rate. We don't differentiate by what card the person is holding.
And with the caveat that there, different decisions could be made in general conversations with CCOs as we built the program. What Nora just said about how they approach it was generally speaking how everybody indicated they would approach it, is not trying to get into that differentiating piece.
Yeah, in addition to it being, we don't want to give an incentive for providers to treat one patient and not another, but also it would be complex. You'd have to be doing a lot behind the scenes to say, okay, this person, you pay this.
Thank you.
Great conversation. Roger, turn it back over to you.
Yeah, I think next slide. We're ready for a 10-minute break here.
Before we jump to the break, I know we're going maybe a couple minutes over time, but I want to see if there's anybody who has any questions about what Roger and Tim have presented so far. I have one or two, but I want to open up to the group to see if there's any others that people have, because there's been good discussion so far, and I don't want to lose the momentum we've had so far. All right, well, I'll jump in while people are thinking if they have any. So I've got two questions. So the first one is, and you may not have this information because I know generally how it works on the CCO level is that information doesn't start flowing in until maybe March or April with a lot of the previous year. But do we know how well OHP's budget is tracked so far? It sounded like there was a lot more unknowns trying to figure out this population than maybe the CCO population on the OHP plus side. Can you speak to that at all? Do you know how well we were able to kind of forecast the costs related to OHP Bridge?
I mean, to my knowledge, I don't think we have had the ability to do any of that analysis yet. I mean, in part because, claims costs from December could still be getting paid, and like how that runs out for the experience of that CCOs have in these first 6 months. So I don't think we have a very good answer to that yet in terms of what cost the CCOs are facing relative to the expectations.
Okay, that's helpful. And then the final question I had is, I notice in the rate setting process, the quality pool dollars are taken out. And if I understand it correctly, normally they do that. And then there's 4.25% that are allocated to the quality pool, if I understand it. Is that the same process for OHP Bridge? Is there like a 4.25% or whatever number is set aside for the OHP bid population? And then if the CCO meets it, they get that money back, or is there not money attributed to the quality pool?
There is not a quality incentive program as of yet for OHP Bridge. It is generally speaking on the radar, but it's too complicated to just sort of like do it all the same, in part because populations are different and you'll have movement in and out, and the program was going to only be in place for 6 months of 2024. But it is intended to continue to look at this and develop a strategy that either, you know, can take some from the existing quality pool structure, or consider different approaches moving forward as they're relevant. So there's not that same component in rate development for the quality pool.
All right, thanks. I'm going to reserve judgment on that till we have maybe a couple more months of the plan, but I do worry about that, not even from it filtering onto the provider standpoint. I do worry about it from the CCO lens, given the fact they have such small margins relatively for administration, where for what would traditionally be 4.25% that they're theoretically potentially able to get, and maybe they're expecting when they're doing their budgets every year, knowing this population, it has the exact same PMPM coming in on their 820 or whatever that file is, and then it's not a part of that population. So I don't know how to kind of reconcile that right now, but I do have some worries that there is less funding in that sense through the OHP bridge than there is on the OHP plus population. Tim, for some reason we can't hear you, even though I know you're unmuted.
Sorry. Yeah, I totally hear all that, and there is a lot to be figured out for developing this. I think this program being so much smaller than OHP Plus, for instance, only at the moment 30-some thousand people, measuring the performance on a smaller population. Some CCOs may have only hundreds of people in OHP Bridge, or very low 4 figures, and being able to duplicate the quality incentive program structure for measuring that the CCO performance on these metrics would be very challenging. And so that's kind of there's multiple reasons for the not doing this right away. And that's one of the big ones. Obviously, we also have many of the incentive measures that wouldn't apply to OHP Bridge. If you're talking about something related to children, for instance, there's nobody under 18 and under on this program. And so it is it is intended for us to like consider and develop quality strategy, but we just don't have a structure for it yet. And I would add, one of the big things that we did in building this program was we met extensively with the CCOs to make sure that we weren't developing an operational structure that would have been too cumbersome for them to implement. And this was an area where, in general, and I won't say like every single CCO, but the general feedback was, don't do this yet. We gotta get the program situated. It's going to be part year. We're still going to be figuring a lot of stuff out, and adding new components with that level of uncertainty or duplicating this structure would have been, or was viewed as operationally more challenging. And so that was another reason. I think there's multitude of reasons why the decision was made not to duplicate the quality pool initially. All that said, I think your points are right on and are exactly why the decision wasn't no, and we're never coming back to it. It was like, we can't do that right away in 2024. Let's keep talking about this and working to figure out what we should be doing going forward.
Okay, thanks, Tim. And then Dr. Hall will end with you, and then we'll run to the break.
I'm happy to save this for after the break too, if we're pushing the break too long.
So normally I would have you ask your question because we're right at a nice 2 o'clock.
Okay.
Let's just go ahead and save it for when we come back from the break.
Okay.
So everybody take a quick 10-minute break. We'll be back at 2:10, and then we'll dive into Dr. Hall's questions, and we'll have Roger and Tim continue with their presentation. All right, so I want to welcome everybody back. It's now 2:10, so we'll go ahead and re-adjourn the meeting. So I'm going to turn it over to Roger, who's going to continue with his presentation on rates and rate setting.
Great. Thanks, Mike. We could go to the next slide. Yeah. All right. So we talked about rate development. Just going to dive into some of these assumptions even more. For our capitation rates, we have these different rating regions. As you could see in the green, we have the central and eastern. The blue is the southwest. Got the darker orange is the northwest, and then in the middle or top area there, you got the tri-county. Yeah, just know it's just think about how many people are in each of these areas who live there and what's highly populated. So we kind of group them together and just get some credibility with the regions and how we could, explain the risk for each of the regions. Yep. All right, next slide. We'll talk about member risk now. A big key word in our world is acuity. When we think about like low acuity, you can think of things like the runny nose or the UTI, the urinary tract infection. Lower acuity refers to like a patient's illness or injury that has a low probability of becoming more serious or developing complications. You think about people with higher acuity, they've experienced a stroke or trauma at the hospital, car accident, something like that, or a mental health crisis. Those are like higher acuity, and that could lead to more serious and developed complications. Just know that CCOs with higher acuity members will receive higher rates. And we're going to look at the differences in CCO rates here soon. I mentioned this before that OHA actuaries and the actuaries at Mercer, we use the CDPS, the Chronic Illness and Disability Payment System. It's a model that looks at all of these risks and allocates rates to the CCOs, gets you that risk score. And that looks at different disease and diagnosis codes, looks at different prescription drug codes. Yeah, so I just want to talk about that acuity keyword there. Yep, could go to the next slide. All right, let's get to some results here. We talked a lot about theory and all that. As you just think about this, this makes sense. We got the rates by different age categories across all the CCOs. The 19 to 34-year-olds are $377 per member per month. And on average, of course, it depends by CCO. Then as you get older, goes 541, then 737, then $866 for the oldest population there. Statewide average is $601 for a capitation rate, paid monthly. So I hope that makes sense. Just younger people tend to be healthier. Older people tend to have more healthcare costs. So you could see that this makes sense on the reimbursement of rates here. All right, we could go to the next slide. It's good when the data like makes sense with what we're trying to do. So that's good. This is all public information. If you want to read more about our BHP rate certification, you could always go to Oregon's website and search for BHP rate certification. So I'm just sharing with you all of the CCO's PMPM rates that we're giving for capitation rates. The statewide average is $601, but each of the CCOs vary, the lowest being $504 a month versus $796 per month. Trillium Community Health Plan, Tri-County is the lowest at 504. Columbia Pacific CCO LLC is the highest at 796. I look quickly at what's going on here, and it's pretty simple explanation. I think you all could kind of guess, but Columbia Pacific CCO has an older population. Of course, we look at their CCO specific factors and all that, but they have a little bit older population, more in the higher age range. And then Trillium Community Health Plan has people more in the younger age bucket. Yeah, so age is very important here. Okay, we can go to the next slide. I'm going to talk about BHP risk corridor, and then Tim's going to take it for the RAP payments. But there's
Roger.
other financial features for OHP Bridge, BHP. Very important. The BHP risk corridor. This is a mechanism to share financial risk between CCOs and the state. As I mentioned before, we came up with these capitation rates. We could be right, we could be wrong. We made sure they're actuarial sound, but some CCOs could come up ahead, and some CCOs can, like, maybe they won't have enough money. So in 2026, we're going to look at like all the experience, and if a CCO's costs are in a certain threshold, there might be a situation where the state asks for some money back, or the state gonna give money. So the hit is not so bad because this is financial risk here. And yeah, we do a risk corridor settlements. That's just how we settle the amounts there. Yeah, and I think that's what I want to talk about on that risk corridor. Tim, do you want to talk about RAP payments and our decision there?
Yeah, certainly. And so there is so backing up a little bit, as we've talked about, a lot of the structure of OHP Bridge is based on Medicaid, the rate development, consistent with how rates are built for Medicaid, but there are some differences in program operations, right? And one of them is related to what are called PPS RAP payments. And these are, I'm certain there's others actually on the call who are like, more experts in this structure. And so I'm going to try to do a pretty high level overview here. There is a Medicaid payment mechanism for certain clinics, federally qualified health centers, some rural clinics, some tribal clinics that develop a Medicaid payment structure a little differently for these clinics. And then based on the experience and the cost of providing services to the Medicaid population, there's something called an encounter rate that's set that the clinics get for delivering services to Medicaid members. When, for instance, if an encounter rate is set at like $200 and a CCO payment to that clinic is $100, the state makes an additional payment of that $100 to get it up to the encounter rate. And I'm like way oversimplifying this whole thing to be sort of more conceptual here. And I've said this already, but I'll say it again. This is a Medicaid payment rate structure that is set at the federal level, and that how state Medicaid programs pay clinics. We are not duplicating that payment structure for OHP Bridge. Like other clinics who don't qualify for these RAP payments, the payments from CCOs will be dependent on the CCO provider relationship and negotiations and their agreements. It's worth noting that This decision not to make these payments was largely a financial one. In the initial launch of the program, there's a lot of uncertainty as to what the federal revenue the state will have in order to operate the program, uncertainty as related to the costs of the program, who will enroll, but also a great deal of uncertainty as to what the population looks like relative to Medicaid. And these encounter rate calculations are based on a Medicaid population. And frankly, this population is a higher income population and will have different characteristics than Medicaid, different healthcare needs. And we don't know enough yet to know how they compare to frankly, to duplicate this structure. And so the decision was made not to include these payments initially, to both continue to work with clinics who get these payments for Medicaid, to understand the patients that they're seeing for OHP Bridge, and to better understand the revenue and costs of the program, and consider down the road whether this same mechanism might be used, or whether an alternate funding structure could be considered to bolster payments to these clinics, even if it's not in the same manner as in Medicaid.
All right, thanks, Roger.
And yeah, and
Sorry,
I see there's a hand up, but
Yep.
yeah, no, go for it. I guess the only other thought that I would say is we did get explicit federal approval that we could make these payments from the trust fund. So if there is funding available, or if the state decides to do this or something similar to this, we do have legal authority to use the trust fund for such payments.
All right, thanks, Tim. Dr. Hall.
Thanks, Tim. I thought you did a great job of explaining that. I'm a provider at an FQHC, and so I think it's helpful to provide a little some additional information, if that's okay, because
please.
I think Nora, what you said, Nora, I think it was you, Nora, when you were saying that you really don't want providers getting paid differently for these patients versus standard Medicaid patients, because that incentivizes providers to treat certain populations and not treat other populations. With FQHCs, these wraparound payments that they receive, the intention of those payments is to we also see patients who are uninsured, and part of our federal requirement is that we have a sliding scale, and for a lot of these patients, they receive zero cost medical care. That this wraparound payment helps to cover those free services that are being provided to these uninsured patients. And so it becomes this really delicate balance of making sure that you're seeing enough Medicaid patients so that you can then provide these free, essentially for some patients, free services. Because if you get out of balance and you're providing a lot of free care, then you're not going to be able to keep the lights on, and you're not going to be able to see the other patients, the Medicaid patients, the bridge patients. And so just personal experience, what we've seen is that it's been really hard to throw in this with bridge and with HOP, where it's a different payment structure than the classic OHP Medicaid patients, to predict financially budget so that we are breaking even, because FQHCs, I mean, we're nonprofit. That's our goal, is to at least break even, and it can be a challenge to figure out how to do that. And so just provider lens, FQHC lens here speaking, that it does create a challenge with the bridge population for FQHCs, which see roughly 25% of the Medicaid patients in Oregon.
super appreciate the perspective and
All right, thanks, Dr. Hall. Couldn't have said it better myself because I work from an FQHC too, so I can relate. Dr. Hall, while you're still available, I know you had a question before the break. Do you want to ask that now while we've got you?
You know what? It was kind of related to this stuff. I think this slide helped and just yeah. So
Perfect. I'm glad I waited now. Awesome. Make it easier on everybody. All right, I'll turn it back over to Roger and Tim. Thanks for breaking to answer Dr. Hall's question.
Yeah, we can go to the next slide. Thank you all. So my part of the presentation is done. I'll let Tim take the last two slides. So thanks for the opportunity and thanks for all your work here. Really great discussion. I mean, I think that just says like what this group can help influence. We had a lot of discussion about if we meet the budget or plan design or wrap payments and all that. So great discussion for the future. I'll pass it to Tim.
thanks, Roger, and thanks for going through all of the technical stuff. The last couple slides of this section really just wanted to kind of try to wrap it up in a way that like we did a month ago, kind of highlights the level of influence or flexibility that the state has and kind of like where OBAC fits in here. And so we've broken up the expense streams, for lack of a better phrase, into a few different buckets: covered services, payment rates, and kind of like these other payment mechanisms like the quality incentive payments or the REP that we were just talking about. So within covered benefits, there is state flexibility. The state does get to define its service package within the federal essential health benefits rules. So there's language in federal BHP rule that just clarifies that any state offering a basic health program has to meet the same essential health benefits requirements that apply to plans that are sold on the marketplace. That said, there are additional services that are often delivered by Medicaid programs that are part of Oregon's Medicaid program that aren't part of the EHB definition. And so where there's flexibility is covered services outside the EHB. And so we believe, I mean, it would be appropriate, or as we think about the state's flexibility in this, that the committee could offer recommendations for adding additional services or reducing services that are sort of in this optional realm where we cover them currently because it's part of the Medicaid package, but wouldn't be considered essential health benefits. I think an easy example is non-emergency medical transportation. That is part of OHP Bridge. It is part of Medicaid, but it is not one of the essential health benefits. It is not typically covered by marketplace plans. So this is an area where the state has flexibility, and we are using it to deliver additional benefits that wouldn't be available or defined as part of the EHB. For provider payment rates, I think it's a good reminder, as we talked about before, the state does not explicitly control CCO payments to providers. As was said, there is a floor, there is the Medicaid fee schedule that offers the sort of like minimum payments, minimum payment rates, but there is flexibility beyond that. So the committee could recommend state action to influence provider payment rates if the intent was to increase payment rates to providers. There could be something as part of our rate development and something as part of the direction to CCOs to pay higher rates in some certain manner. One could think of it similarly to what are called directed payments in Medicaid, where sometimes the state will make requirements for for the Medicaid managed care entities, in Oregon's case, CCOs, to pay providers in a certain manner, usually to make extra payments to providers. So there is, again, some level of flexibility there, obviously with the caveat that we couldn't, that there are barriers to changing that the state would need to consider, right? There's operational challenges if there are different rates. There are certainly barriers to reducing provider payment rates, because then providers might not be interested in participating, or the CCOs might not be interested in participating. So there's still concerns and considerations related to that flexibility, but it is an area where the state has some flexibility. And then thinking about new and other payment mechanisms. And again, these are all, funding dependent. If there is available financial resources in the trust fund or through a state appropriation, then there are lots of options that could be considered for additional payments, either for to duplicate something in Medicaid like the RAP payment, to fund something akin to the quality incentive program, or to make additional investments in the program, in CCOs and providers in a different way. And so again, it's another area where depending on funding, there could be state flexibility. And so then the last slide is around the funding streams and their flexibility. And I believe we included this one a month ago when we talked about this. And so it's a good reminder that there's areas where we don't have flexibility. The federal payments, both to Medicaid for Bridge Basic Medicaid and to the trust fund for the basic health program, are defined federally, right? We don't have any control over what we get from the federal government to operate these programs. General fund is in the state's control. So if the state decided to increase investment to make up for lost federal funds, for instance, or to add benefits, or to do something else, that is part of the state's control. Obviously, it's not fully in the control of the committee, or even OHA, or even the governor, but it is, broadly speaking, the control of the state. And then similarly, any member cost as a way to either raise revenue or reduce program spending, there is flexibility there. Again, there are federal rules that define what the state can and can't do when it comes to member costs, when it comes to premiums or copays or deductibles. And the broad consideration is that it can't be any higher than these than members would face if they were enrolled in a marketplace plan. If the state didn't have a BHP, folks would have premiums and potentially copays in a marketplace plan. States that do have a BHP cannot make it any more costly on members than it would be in those. As we've said before, there are currently no member costs in OHP Bridge. That is matching the structure of Medicaid. And again, while there is state flexibility, there's a host of operational challenges that would also come to bear if the state moved in that direction. With that is done with the slides, but certainly happy to continue to answer questions if folks have outstanding comments or questions.
Yep. Open up to
And
the
there are a
floor.
few more slides when we're done, but sorry. As an aside, and I think I meant to say this when we were back on the other slide, the slide right before this where we talk about sort of expense streams, covered benefits, payment rates, other payment mechanisms. Next, at the next meeting, this bucket right here is kind of what we plan to go into a little bit more depth about, a little bit more information about covered services, for instance, so that folks have a better handle on how the program is structured as it relates to these areas.
Anybody have any questions, or any OBAC members have any questions for Roger or Tim? Okay, I think that was an awkward enough amount of silence, so I'm going to take that there's no more questions. So I want to thank Roger and Tim again for presenting today. That was a lot of really good information. Also, I think some really good questions and discussions around what was presented. So again, I want to thank both of you. I wouldn't be surprised if we try to pick your brains a little in the future, but I think this will be a good foundation for us moving forward as we start to develop what to do for OHP Bridge.
Thanks, Mike.
So
oh, Mike, can I just add one thing? Yeah.
feel free, Roger.
So yeah, just to recap, during the COVID time, yeah, we had people ramp up and get Oregonians got coverage, and the state wasn't allowed to take them off, and we just didn't want to have that churn when that temporary program stopped. So we created the Bridge program and had people on the program and get the health care they needed. And so far, we got like 32,000 people on Bridge, and we've got this up and running. So I think it's all a great thing that we've done this, and you're part of the committee, and it's all a good thing here. So thanks for everyone's work here on that.
All right, thank you, Roger. That's very appreciated. Okay, so now we're going to shift over to our public comment portion of today's discussion. So I'm going to turn this over to Katie, the OBAC staff lead, who's going to provide a quick announcement about assister and community partner questions.
Yeah, thank you, Mike. So we had some questions last month regarding kind of how the community can interact more with this program and the purpose of these meetings and whatnot. So we wanted to make sure that we were making folks aware of one of the kind of key areas that we have for community engagement. And that's especially for our assisters and community partners, who are just a really vital part of this program, and making sure that the word gets out, that folks know how to navigate various components of OHP Bridge, including the application and eligibility, things like that. So we wanted to make sure that there was a space for our community partners and our assisters to reach out to us with some more technical questions. And so every month we receive questions from our community partners and sisters, and we bring them together. We get a group of subject matter experts together to analyze those questions and make sure we've got good answers for them. And then we present them every month at the Oregon Health News monthly webinar, which happens once a month, once in English and once in Spanish. I believe the English meetings are on the second Tuesday of every month, and the Spanish ones are on the third Wednesday, but I'll have the dates up here in a moment. So I wanted to just flag a couple of ways that people can submit questions. So you can submit them through your community partner outreach program, so your CPOP Rocks, your regional outreach coordinators, and they will send them our way. You can also send a written question directly to our OHP Bridge email, which is on the screen, and I'll be dropping that email address in the chat here in a moment as well. Or you can just attend the Health News webinar virtually online and ask questions during the question portion. So as I mentioned, we collect all these questions throughout the month. We do close the sort of question box about a week before, so that we have time to get everybody together and answer the questions. If you submit a question after that week timeline, it's not a problem. It'll just be sent to the next month. And then we also send the response to those questions out to the original inquirers following the meeting. But we do first present them at the webinar, in part just to make sure that if one person has a question, a lot of people probably have it as well. So we want to make sure that as many folks as possible are kind of accessing the knowledge. I do, actually, before I change slides, I do want to flag this OHP Bridge email is predominantly there for our partners and our assisters. We do want to note that it's an extremely small team that manages this email inbox, so we can't answer questions related to individual cases. That is for the one system and our assisters and folks that specialize in our member outreach and assistance. So we do want to make sure that folks aren't sending really vital, time-sensitive questions to this inbox. There is an automatic response on it that will get you the information you need for who to reach out to, but the purpose of that inbox really is for our sisters and community partners who have technical policy questions, so we can make sure that we're getting them the support they need so that they can support our members and future members. So that Oregon Health News webinar is, as I mentioned, hosted once a month, both in English and in Spanish. So the dates are on the screen, and then there's a link that will be accessible via the slide deck that's posted online. And the link is here on the screen, but I know it's not one that you can use right now. So I will drop the information that I have in the chat, as I mentioned. So we just wanted to make sure that folks are aware of that because we do really want to make sure that our sisters and community partners are getting those answers that they need, as I said, so they can support our members and future members. Okay, I think I'm handing it back to you, Mike.
All right, thank you very much, Katie, for that update. So we're now in the public comment portion of the meeting. So very briefly, I've got a couple housekeeping items just for everybody to be aware. So the OBAC welcomes and deeply appreciates public testimony, which you've mentioned in the past. However, to be respectful of everyone's time and ensure we are focused on listening, we will not respond to what you share, nor will we attempt to fix or resolve the question and concern that you bring today. We will also not interject to correct incorrect comments that are shared as fact. We will, however, take your comment seriously, understand it is an important consideration for our work, and listen with careful attention and respect. We want to acknowledge that time held in our meetings to hear public testimony is meant to provide a voice and a perspective from that individual and is not a representation of the OHP Bridge Committee, its members, or the Oregon Health Authority. Each presenter is given 2 minutes to share. In the event that doesn't feel like enough time, we encourage you to provide written testimony, which we will commit to reading. To help keep us on time, we'll start a 2-minute timer for each commenter, which you all can see hopefully on your screen right now. We kindly ask that commenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the committee chairs and staff to determine the appropriate next steps. If it looks like you're over 2 minutes, I will interject and I will have you stop with whatever thought you're saying so we can continue to allow other folks an opportunity to provide comment. As a final reminder, staff will not be responding to questions posed during public testimony in order to ensure that the focus remains on listening and that there's an adequate time for all commentators to participate. Staff are working to build a tracker for the OHP Bridge Advisory Committee website that will track questions from the public that were posed during public comment and provide written answers. If needed, public commenters are welcome to share their video while presenting public comment, but we ask that you keep the videos off during the remainder of the meeting to reduce bandwidth capacity issues. So having said that, I will now open it up to the public. If you would like to provide a comment, please raise your hand and then we'll give you opportunity to share what you have to provide and we'll listen. I'll give it just a little bit more time just in case, because we're asking the public to comment, not members. Okay, so I guess we don't have any public comments today. All right, well, that was an easier one than normal. All right, so in closing, I want to thank everybody who provided comments today. We truly appreciate your time to share your thoughts on the committee. Before we close out today's meeting, a few reminders. First, if you'd like to sign up to provide public testimony at next month's OBAC meeting or your community partner or sister with a question on OHP Bridge, please reach out to the email that you see on the screen in front of you. Secondly, if you'd like to sign up for the new OHP Bridge mailing list to receive updates and announcements related to OHP Bridge and the OHP Bridge Advisory Committee, you can do so at the link that's also on the screen just below the email. Lastly, you can find out more about the OBAC, including its meeting times, meeting links, and meeting materials at the OBAC website using the link shown at the screen. That's the one at the very bottom. As a reminder, our next meeting is on February 13th from 1 to 3 p.m. I look forward to seeing everybody there. I want to thank everybody again for attending today's OBAC meeting. I'll turn it over to Katie for any kind of final announcements we have before we close.
Yeah, thank you so much, Mike. So I just wanted to flag that all of the links that I mentioned and that were up on the screen there are now in the chat. So we'll give you a moment or two before I close this meeting out for folks to copy those if they need them. So we just want to make sure that folks didn't miss that. But otherwise, as Mike said, we really appreciate you all coming today. And we look forward to seeing you next month at our February OBAC meeting.
All right. Thanks, Katie. Having said that, I think we can adjourn. All right, take care, everybody. I'll see you all next month.